Hey everyone, welcome here or that's hello, Kate and Jessica. Did I not hit the OK button? Oh my goodness. I think I forgot to hit the publish button. Not smart of me. They're posted. I didn't hit the button. Okay. Try reloading your page now. I got the first two up. I'm doing a couple updates to some other ones. Yeah, so you can check that out. Sorry about that. Let me start here in just a minute. Let me know if you guys see it now. Perfect. No. Great. I'm glad that's working. All right. Hard to believe we're in our last home stretch here, last quarter of the class. Pretty wild. I'm just looking up a couple of things. Whatever. Hopefully everyone had a good weekend. It's been like a week since I've seen you all. Wow. 23 months. That? All right, it's 12:30 on the dot. Recording going. Had a couple questions here. Someone said if someone uses testosterone and their levels are high or normal, does this increase risk for prostate cancer due to excessive growth due to all the extra DHT? It could. Certainly you'll see more if you're giving testosterone specifically, you will see that will be converted. Hard to believe is the last one, huh, Priya? So yeah, some of that is going to be converted over to DHT, and certainly you can see some growth of the prostate there. That growth may manifest as cancer potentially, depending on risk factors and all of that, genetics and whatnot. Someone's asking about geriatrics, which we'll get to in the next section, but someone's asking, elderly population tend to have more adipose tissue and less total body water. Does this mean you'd have to increase the dose of lipophilic drugs and decrease dose of hydrophilic drugs, or do you have to decrease the dose for both types? That is, that can be dependent on a couple of factors. You'll frequently see more often than not that their issues in terms of like drug dose adjustment are more so on things like based on organ function, right? So things like, how often you're giving drugs may be affected by that. The overall total dose may be changed to some degree, depending on organ function, primarily kidney function being one of the biggest ones we look for. But you may see in some cases, especially depending on how obese the elderly patient is, we sometimes will put caps on how much we may increase the dose of that lipophilic drug. So as an example, if you have a drug that you dose, say 1,000 milligrams per kilogram, it's probably not a good option. How about 15 milligrams per kilogram? And we would normally say, okay, well, if you did that, then, if you had someone who weighed 400 pounds in the ICU, like, you may find yourself that would be a pretty ridiculous dose that you're getting up to if you just multiply that out. So sometimes you'll see max doses that are capped in there, or sometimes you may see where we use something called the adjusted body weight, where we will look at the patient's ideal body weight, look at their current body weight, and then there's a calculation you can do basically to figure out what their adjusted body weight should be. And so we dose based off of that and then kind of monitor for response, or check levels or do things like that. So that is more often the case where you run into issues like that, and certainly total body water being lower based on their weight, you could see some issues in the hydrophilic meds where you may need lower doses in order to get the concentrations you're shooting for. It's very easy to overdo it in some cases for those elderly patients. But we'll talk more about that later for sure. Okay, so everyone can see the section here on HIV and STIs. I apologize, I did not update the section thing here, but that's okay. Switching over to the PowerPoint so you guys don't yell at me. Anyway, yeah, so we have a couple things we're going to be covering here, so kind of a bit of a hodgepodge. So we're doing HIV, STIs. First, we'll do geriatrics, and then I'll post up the immunizations lecture. I'm still updating that. I wanted to add in some stuff about like the COVID vaccines and mRNA vaccines, and then we'll do ER stuff, and then that'll kind of segue into a little bit of talk about toxicology, at least some of the things that I would like more PAs to know about when you guys get out there and start practicing. But anyway, let's talk about HIV, because this is a very important set of patients here you're going to be dealing with. It can be sometimes a challenge to manage just from a variety of different reasons, but also because these patients are living a lot longer. And so we can see that there's going to be more of these patients are living for longer. So you're going to happen across more of them, and having to manage both their antiretroviral drugs in addition to whatever else you might be prescribing for them. It's really important to kind of keep in mind what kind of interactions you're going to run into. Some of the HIV drugs will cause metabolic changes that you may have to be dealing with, such as like diabetes and hyperlipidemia. And even if you don't work specifically in, dealing with infectious disease, working with HIV patients one-on-one, you may still happen across them all the time, whether you're in the ER, if you're in derm, if you're in ortho. I mean, like, these people are living for longer, and so you can find that they still have other medical conditions they're dealing with. And so just being aware of that and being aware of like what type of interactions you're looking for and things like that are very important. But anyway, so we're going to talk about our highly active antiretroviral therapy, or HART therapy. You may sometimes see it referred to as that. It is used to treat the human immunodeficiency virus, right? It's a retrovirus. You'll find that there are two main varieties, HIV 1 and 2. We'll find here in the US that I think one is a little bit more common here, but in some cases, in some places, you may find that HIV 2 is more predominant. That will have some impact in terms of which medications you can use, but most of them tend to be pretty broad spectrum and will treat both varieties there. And certainly, you'll see that sexual contact is going to be a big cost or spread for this. Parenteral spread due to things like sharing needles and whatnot. You could see this with like contaminated blood products, which is pretty rare nowadays, or even perinatal transmission. And so I'll talk a little about later on about treating patients who are pregnant mothers who are HIV positive and what we do for the baby. I'll talk a little bit about post-exposure prophylaxis, or PEP, that we do for like healthcare providers who might have been like stuck with a needle by a patient who has a HIV. So we'll kind of talk about those little points there. And then the big problem here is that the HIV is going to deplete the patient's immune system, right? So it's basically going to wipe out their CD4 cells and make it very difficult to fight off, routine bugs that we encounter all the time, like, PJP and things like that they just cannot fight off. And so they get a lot of these opportunistic infections, which is oftentimes what they ultimately succumb to. And so, toxoplasmosis and cytomegalovirus and all kinds of things that, normally you don't see in immunocompetent patients. But and the big reason why we cover it here is because it's drug therapy is the main way we treat this. There's not a lot of no real surgical options and things like that, unfortunately. So this is a pretty busy slide, but I think it's good because it kind of shows you the HIV life cycle, and then sort of where our different drugs are going to be playing a role here. And so I will tell you, this is a bit of a bugbear for some students because it can be challenging to categorize all these drugs into their various categories because a lot of them have very similar naming conventions. So like a lot of things end in vir because they're antiviral drugs. So this can be a challenge, but again, I think you'll be able to handle it, no problem. You guys are all very intelligent. But basically what we're going to see is that the HIV virus is going to come along and eventually is going to try to enter into one of your cells, and predominantly the ones that express that CD4 receptor. There is going to be an integration that happens here, or I'm sorry, not integration, but more of a fusion that happens here that will allow for the drug to come in. We'll talk about some things that help to prevent that entry in the first place. And then it will then uncoat and release this RNA. It has an RNA polymerase that will then cause it to form DNA from that, and then will incorporate that into your own DNA, right? So then that's why it's a retrovirus, because it takes the RNA and then will take that DNA and then insert it into yours. So now your cells are now producing the virus for it. After that has occurred, occurred, once you have the translation of the viral DNA into protein, it then has to undergo some chopping where it will become functional proteins. It can then reassemble itself and then will bud off and go and attack a whole new cell. So the reason why I kind of focus on the life cycle is because if you understand where the drugs work, you can kind of understand how we can interrupt this process here in terms of like the medications we're going to use, because you know, and again, this changes all the time in terms of like what the most up-to-date recommendations are, because this is a pretty sloppy virus and causes a ton of mutations in itself all the time. So resistance is an issue. You're going to see that, like, you know, initial recommendations for treatment is going to change over time. You know, and so I'll get into some of those more fine details as we get into it. So anyway, so you can kind of get into more of the details here, but again, it's looking for the CD4 receptor presenting cells. There's actually a CCR5 protein that some of these will be looking for too. It's kind of like a co-receptor that it'll bind to. And again, once it has that fusion occur, which will be a drug target we can focus on, it'll internalize that virus. And again, this is where we're going to see that reverse transcriptase start to work. This will be a big target for some of our medications. If you can prevent that reverse transcriptase from forming that new DNA, then it is not going to be able to get incorporated into your DNA, basically. So we'll see there's some ways that we can try to do that. But again, very error prone, very sloppy, so it makes a lot of mistakes and mutations, and that's why it can be a challenge. We'll talk all about resistance testing in just a little bit, but yeah, this can be really tough, especially for patients who are, you know, non-compliant. Compliance is such a huge issue for these patients that, you know, in some cases, if they're not going to be compliant, it's almost like you might as well not even treat it, because of the fact of in some cases, when you have a mutation, you can almost lose like a whole drug class. In some cases, it can be so severe, but we'll talk about those details there. Anyway, once that reverse transcriptase, it'll form some new DNA, and as I mentioned, that mutation leads to a lot of that drug resistance we're going to see there. It'll then get incorporated via the enzyme integrase. This will be a very important enzyme we're going to look at in just a little bit, and then now your cell is basically producing the virus for them until it ultimately dies off. We'll basically see sort of three main phases for the infection, and this is why it can be kind of tough, because a lot of these patients may be like asymptomatic for a while before you even realize they have it in the first place. They may have an initial sort of acute retroviral syndrome, but you could kind of like just, you know, pawn that off as just kind of having a random illness, and they may not think anything of it. But there'll be a latent period they kind of get into. And then once it is sort of discovered and they have this immunosuppression happening here, you kind of go into that chronic sort of phase. When they develop one of these AIDS-defining illnesses, that's when they are considered to have AIDS at that point. So things like PCP, Kaposi sarcoma, there's a whole list of them, some of which I'll talk about treatment for in just a little bit later. But again, you know, I could almost do an entire class just based off of, you know, drug management for HIV patients. I know I had a whole elective I did one semester just on this stuff. So certainly a lot to it. But again, I'm trying to give you sort of the survey sort of starter course for this. Anyway, in terms of monitoring, what we're going to be looking for are going to be the CD4 cell count and also the viral load. We would like our CD4 count to be high. We want our viral load to be undetectable. That is always a goal for the viral load. If you can't measure in the blood, that means they're making so few copies that they are not really able to sufficiently go and attack all these other CD4 cells. So Our goals for these patients, and again, this is something that's pretty wild because even like during my lifetime, like, so I was born in the 80s. That's when really the AIDS epidemic really started. A lot of these patients had like no life expectancy whatsoever because we didn't have drugs to treat it back then. But even in this relatively short time span, 30 years in the grand scheme of cosmology, but in 30 years we've really revolutionized how to treat this, and we have patients that are living for much longer to where they're usually dying from other things, so dying from like heart disease and all the stuff that other patients who don't have HIV normally die from, right? And we do that by having maximal durable suppression of that HIV replication. So that's why we want that undetectable viral load there. But otherwise, we would like to preserve their immune function to make sure they don't get any of those opportunistic infections we mentioned there. Try to prevent transmission if at all possible, right? So certainly good patient education is important there. But we can look at some ways we can try to look at that, especially if we have like serodiscordant couples. The one patient has it, the partner of that patient does not. There's some ways we can try to mitigate transmission there. And then overall quality of life would be good to shoot for, right? I think everyone wants better quality of life. Anyway, so our goal here, as I mentioned, is to try to disrupt the replication of the virus. And we're going to see there's lots of ways we can do that. And oftentimes we're going to need multiple medications in order to make this happen here. By looking at the RNA levels, that'll tell us how active the virus is in terms of replication. CD4 count tells us the extent of the damage to the immune system. So the lower the CD4 count, obviously, the more destructive the virus has been, the more likely they are to develop, immunosuppression or develop, some of these opportunistic infections. Jackson's saying some of my preceptors from medic school talked about running calls on HIV positive patients in full level A suits in the 80s because they knew so little about the disease. Yeah, that's wild. I mean, I remember like seeing like news stories, not when I was a child, but like seeing in since then about how like I think like Princess Diana back in the day, she would like shake hands with AIDS patients because to show that it's like, hey, you can hug these people, you can it's not like you're gonna catch it just from being in the same general area. But back then, like if you don't have knowledge, you don't know, and so it can be pretty wild. I mean, we've even seen development of knowledge about a new disease state very quickly here just in the past year or so. So pretty wild stuff. But so anyway, so we're going to be trying to keep that CD4 count up, keep the RNA level undetectable, and to do that, we frequently need to have usually 3 or more agents that we're going to be treating these patients with. And again, back in the day, I mean, they'd be taking dozens of pills a day just to be able to suppress this virus. But nowadays, I mean, there's some options. It's just like 1 tablet a day. So again, things have gotten markedly better for these patients in terms of their outcomes, in terms of being able to be compliant and not really disrupting your lifestyle nearly as severely as it used to, which is fantastic. And so again, why we focus so much on the resistance and being compliant is because this is something where we don't have new antiretroviral drugs coming out all the time, and so we want to make sure that we keep patients we keep the virus susceptible to as many options as we can, because otherwise, if you start to become resistant to multiple options, you may not have a whole lot of good options available to you, right? So this is why it's always a challenge for some of these patients where you're like, I need to switch them to something else that the virus is susceptible to, but we don't have a ton of options, or the options we do have are really not great from a side effect profile, which is unfortunate. But so there used to be kind of a question in terms of like when was the optimal time to start treatment, and this is pretty interesting because even back when I was in school, from 2006 to 10, this was still a question. People are like, well, do we start treating at like CD4 count of 200? Do we do it at 50? Do we do it at 100? The thought process back in the day was that you want to hold off, and because we had so few options in terms of drugs, they said, well, let's save our drugs for as long as possible. And so they would, wait until patients got to CD4 counts of like 50 or 100, which is unthinkable nowadays because we know that those opportunistic infections are more likely as that count goes down. So nowadays, if we know someone has HIV, they just get started, right? Because we can preserve that immune system for as long as possible there. And so this also helps out with things like reducing transmission, fewer AIDS-defining illnesses happening here. So again, that's why we start everyone just right away. As soon as you detect it, go ahead and start it. So here are the main drug classes we're going to be running into. We're going to have our integrase inhibitors. We're going to have our nucleoside or nucleotide, doesn't really matter, reverse transcriptase inhibitors, or NRTIs, as they're frequently called. We're going to have the non-nucleoside reverse transcriptase inhibitors. That one's kind of a bugbear between the two there to make sure you get those straight. But there's the NNRTIs. You have the protease inhibitors. We'll have our entry fusion inhibitors and our co-receptor inhibitor. The main classes that are going to be sort of the most commonly used are going to be these first four that are here, and particularly the NRTIs are oftentimes the backbone of a full heart regimen. We'll talk about that in just a little bit. But one of the things to note here, and I'll probably have this later on, but the recommendations for this stuff always changes. And so the stuff I tell you now might even be out of date by the time that you graduate, right? So you can go to aidsinfo.gov, I think that's the website. HIVinfo.nih.gov, or you can just Google, AIDS info. And that is a really good website run by the National Institute of Health that has all the up-to-date recommendations. They have all the guidelines. Everything is there, free to use, and a lot of good education, resources for patients too. So it's a really, really good website there. So anyway, so let's get into the drug classes. So let's talk about our nucleoside reverse transcriptase inhibitors. These are, and this will actually look pretty similar to what we saw with some of our other antivirals like acyclovir and things like that. But, and again, you'll notice I have a lot of abbreviations here. You don't need to memorize these. I'm just presenting them to you for sort of like some context. And, like in oncology, a lot of those practitioners love using their abbreviations. HIV is no slouch of that. You can see here, zidovudine is often called AZT. It doesn't seem like it makes any sense, but it has to do with the actual chemical name of the drug. So don't worry about memorizing those. I'll certainly present to you both the generic and the brand names on the exam. And I don't care if if it's a deoxyadenine, guanosine, cytidine. I don't really care about that, right? I just care that can you place these drugs into the NRTI class and know how to use them, know the side effects, interactions, etc. Okay, so that's kind of as far as I want you to get with that. But again, be careful anytime you're dealing with abbreviations because you got to make sure everyone's on the same page. Because if you say ABC to somebody and they're not really sure the jargon that you're using, it can lead to confusion, right? And I don't know if you've ever been in one of those situations where someone knows more than you do about something and they go, oh, yeah, you know about this, right? And you just go, you don't want to look stupid, so you just go, I definitely know what you're talking about. Yep. That can be dangerous, right? I always say fake it till you make it, but in some cases you got to be able to admit ignorance. So I'm gonna ask a question here to say, what does RNA polymerase do? So RNA polymerase in the case here with HIV is it is what will take the viral RNA and will copy it into eventually double-stranded DNA, right? So RNA polymerase is really important for that in order to convert that to DNA for then it to be integrated into your DNA. So that's what that is used for, and I'll cover some drug examples here that go into more detail on that in just a little bit. If the recommendations are constantly changing, how we know the guidelines, our PANTS will test on this subject. So generally speaking, a lot of times you're going to find, because that's trying to read oncology notes, like trying to translate code exactly. Anyway, so you'll find that oftentimes these standardized tests are usually behind as well. They're not, we don't change HIV questions on the PANTS the second that the AIDS Info website changes. So in that case there, you will find, some of the stuff has been pretty much the same for a while now. So like the drug classes really haven't changed. The, the opportunistic infections haven't really changed. When to treat hasn't changed in a little bit. So, where the big changes happen are going to be things like what is the initial preferred regimen, right? That usually changes kind of from year to year. I doubt that the PANTS is going to ask you a question like that that's going to get so granular that you had to be absolutely up to date. So generally that's going to be less of a concern for the most part. But sometimes you run into issues where you're like, no, that question is actually wrong. And, there's ways to be able to write in to be like, hey, this should probably be changed based off new recommendations. But I would not recommend doing that a whole lot because you don't really get good feedback to see what you got right or wrong anyway. But okay, so going back to the NRTIs. So basically here we have a pretty decent list, and this is typically going to be the backbone of a lot of your heart regimens. We're going to have stavudine, we have zidovudine, we have imtricytidine, lamivudine, abacavir, didanosine, and then tenofovir. Those are your main NRTIs that you're going to run into. So what do these drugs do, right? So basically we have this reverse transcriptase. This is the enzyme that's going to be utilized to form DNA from that RNA, right? So this reverse transcriptase, RNA polymerase, the HIV virus is using here. Normally what you're going to see is that this requires, just like forming any other type of DNA, that you have a typical nucleotide that has that deoxy kind of structure there, has that sugar moiety on there to be able to form the rest of that chain. And so you'll see it has to require that triphosphate form. Basically, these drugs are going to act as false nucleotides. They're going to get incorporated into this new viral DNA, but they act as that chain terminator, kind of what we saw back in the oncology notes, right? Again, we're using drugs with similar mechanisms. So something like cytarabine did something very similar to human DNA. This is doing it specifically to the viral DNA here. And again, by being specific for that, it helps to save our cells, even though we may see there's a little bit of cross reactivity there. But for the most part, this will get incorporated, acts as kind of like a stopper here, cannot produce any more viral DNA off of this, okay? So since it can't further elongate, can't form the full DNA, the full translation there, or transcription there, so then it cannot be then incorporated into our DNA. So what you're going to find in terms of the side effects here typically are due to some of the inhibitory effects it can have on things like mitochondrial RNA and actually on somewhat on our DNA synthesis, which is why you can run into some of the things we'll see here. And again, a lot of the newer recommendations will start to move away from these older agents because the side effect profile tend to be a lot worse with things like stavudine, didanosine, zidovudine. Zidovudine is actually like the very first antiretroviral drug that we had back in the day. A lot of the newer ones, so things like tenofovir, lamivudine, emtricitabine, and abacavir, are going to be much better tolerated. In fact, if you look at the recommendations, if you go to I think they changed to HIV info instead of AIDS info. It used to be AIDS info. But if you go to HIV info, you'll find there that a lot of the initial recommendations will put, tenofovir, emtricitabine, lamivudine most commonly. The reason why abacavir can be used initially, but you have to do some additional testing, is because some patients will have this innate sort of hypersensitivity. There's a mutation they can have called the HLA-B5701. Now, memorizing that number is not going to be so important, but recognizing that abacavir specifically, you have to do this genetic testing on beforehand, because if they have this mutation, then they're much more likely to have anaphylaxis. If they don't have the mutation, then you're good to go. You can use it, no problem there. That's one kind of unique sort of thing here with abacavir that is not shared by any of the other NRTIs. Other things we can run into, though, in terms of side effects, it can include things like peripheral neuropathies. You see things like pancreatitis that can happen here. You can see this lactic acidosis of fatty liver. That kind of makes sense if your mitochondrial RNA is being affected here. Maybe you're kind of switching over to some anaerobic metabolism. I could see that. Anemias can happen because if you're disrupting those red blood cells from replicating. So again, some of these are going to be more mild with the newer agents. Certainly the older ones tend to be a lot harsher in terms of their side effects. So next we have the non-nucleoside reverse transcriptase inhibitors. So these are a little bit different because instead of necessarily working to affect the strand of DNA that's being formed here, instead this affects directly the reverse transcriptase. So by affecting that directly, it kind of changes the conformation of it and prevents the viral RNA from interacting with this. You can actually have cases where you can use an NNRTI plus an NRTI together, and you do get some synergy there because one's working on the elongation of the DNA, the other one works specifically on the protein, the actual RNA polymerase here, or reverse transcriptase, in order to prevent that from further producing new viral DNA. Sorry, I feel like I have a sneeze coming on. Then like a second I hit mute, and then it goes away. It's very frustrating. So the NNRTIs are going to include delaverdine, efavirenz, nevirapine, etravirine, and then rilpivirine. In terms of adverse effects, these ones are not too terrible. I would certainly monitor liver function, and pretty much in general, liver function is going to be monitored for a lot of these drugs here because they can tend to be a little bit harsh on the liver there. But again, you can see some transaminitis. And these ones you're going to see are not going to be preferred as like your first line set of drugs here for like a new HIV diagnosis, mainly because of the fact that even for a lot of these, except for etravirine, even a single mutation, or there's kind of several predictable mutations that can occur that basically confers resistance against the entire NNRTI class. So if you have a patient who's on dolaverdine and then they develop this mutation, then they couldn't go on to efavirenz, because the whole class would be lost basically. So that can be kind of a challenge, which is why we don't use these first line like we used to, many years ago. Someone's saying here, so NRTIs get incorporated into the viral DNA and act as chain terminators, so HIV DNA elongation is prevented in our cells. Just want to make sure I understand the MOA. That's absolutely right? So just like you would see with cytarabine trying to prevent a cancerous cell from replicating its DNA, in this case here, the NRTIs are preventing elongation of the viral DNA, so that way it cannot get incorporated and take over your cell, basically. Yeah, that's absolutely right. Okay. And I thought I had one. There's another slide here about that. I'm missing some slides. I don't think I'm missing anything. Anyway, so the resistance is going to be kind of the big issue you're going to see with that. So that's one thing to note there. Next up, we're going to have our protease inhibitors. So this is a pretty big class here. And again, these are kind of tough to be able to tell apart because they all end in vir. Again, it can be difficult to place all these in the right class here, but these essentially would be after the viral DNA has been incorporated into our DNA, and now your cell is starting to produce the viral proteins. They have to be chopped up into their more functional portions. If you can inhibit protease and prevent that from happening, you just have kind of this long string of proteins and this non-functional. So this prevents the actual new mature virus from being formed in the first place. And so here we have atazanavir, we have darunavir, we have fosemprenavir, indinavir, lopinavir, nalfinavir, ritonavir, sequinavir, and then tipranavir. Ritonavir is kind of an interesting one, which we're going to get into. There's some unique sort of pharmacokinetic sort of properties to it we're going to look at. It's not unique, but some specific ones we're going to look at here. And so, for example, here you see lopinavir is oftentimes found in the brand name Kaletra with the addition of ritonavir. So it's a combo drug that we're going to see there. Again, don't worry about memorizing the abbreviations. I'm not going to put those on the test. They're just for kind of exposing you to it. These ones, again, are not going to be in that first line list of drugs that are going to be recommended for a brand new patient with HIV because they do cause a lot of kind of metabolic complications in the long term. So, for example, here you can see things like glucose intolerance, increase in lipids. You can even see some lipodystrophy. And this is actually kind of a unique sort of feature of the protease inhibitors where they develop what they call a buffalo hump that can happen here. So this would be sort of a chronic thing you'd see in patients with HIV. Again, because of these patients living for longer, now we do have to worry about things like diabetes. We have to worry about things like heart disease. And so this can sort of hasten the development of those problems. And again, why we don't like them necessarily as our first line set of drugs here. Not to say they don't get used, to say that it may not be the first line thing that we're going to be going with in a lot of cases there. Most of these are going to be metabolized in the liver. A lot of them are actually going to go through CYP3A4 metabolism. And so it's interesting that we can actually use pharmacokinetic interactions to our benefit. So there's two drugs here. One's ritonavir, which we saw as a protease inhibitor. See, Dr. Pimple Poppers entered the chat. Oh, you think for that buffalo hump? That's all fat, though. I don't think you could do anything for that necessarily. Although I've certainly seen some videos where I've seen some pretty nasty abscesses that look sort of like that. But anyway, here you can see that we can actually utilize either two substances. One's ritonavir, which is a protease inhibitor, and one's called cobikistat. These are both really potent CYP3A4 inhibitors. So what we can do is that we can actually use this to boost levels of our other protease inhibitors. And so by using ritonavir, back in the day, before we had access to things like ritonavir, you may need to take like a tablet 3 times a day in order to get sufficient levels to suppress viral replication. If you boost that up with ritonavir, now you can bump it down to like maybe once a day. And so we did this in order to get better viral suppression and to help to increase the compliance with the regimens by making them simpler. Okay, so we'll see these come up again in a couple of places here. But again, less frequent interaction or dosing, but again, tons of interactions. And so this can be a problem, right? Because again, here we have a CYP3A4 inhibitor, but imagine you have a patient who has HIV, they get very immunosuppressed, and now they develop TB. What's a common TB drug that can cause interactions with CYP3A4? Well, they can be on rifampin, and rifampin is going to be inducing CYP3A4. So now they're finding a CYP3A4 inducer that could be lowering levels of your drug, and now you don't have sufficient suppression of that virus, right? So again, these interactions can sort of stack up on one another. You do want to be very vigilant, and whenever you're prescribing new medications, and look for these sorts of things. Moving on, next we have our fusion inhibitors. So we have one drug here called Enfuvirtide. And so this one is interesting because it only works for HIV-1. So this is the one specific example where a drug only works on one strain of the virus, not the other. So for instance, here in the US, you could probably get away with using this drug because mostly we have HIV-1, whereas in places where HIV-2 is more endemic, I think places like Africa, I think has a higher proportion of HIV-2, this drug would not be very useful, right? Because it's just less likely to be present in those patients there. Again, why that distribution happens, I'm not really sure, but I'm sure someone has some ideas. This is a protein, so again, it will be an injectable product, and everything else we've looked at so far has been oral, right? So that's kind of at least one benefit with their antiretrovirals, at least their oral products. But here we're going to see that this one cannot be administered orally, it has to be injected. And so again, you can see things like pain, erythema. You'll see this definitely not used on the top of the list for recommendations. It's kind of used as an adjuvant if they become resistant to sort of other drugs, as we'll see when we look at the resistance testing in just a little bit. But again, make sure they're kind of spreading the site around. They're not injecting at the same site and kind of get these nodules to form. Make sure they're using good aseptic technique because they have to, make sure you're not getting skin infections and things like that. And so again, by preventing the virus from fusing with the cell in the first place, you prevent it from ever getting in. So kind of like, putting up the gates a little bit and saying, okay, virus can't enter the cell in the first place. So someone's asking, so what if protease inhibitors boost levels of? So specifically ritonavir and cobicistat, you can combine that with other protease inhibitors, or look at some other examples here coming up where you can boost the levels of those drugs. So for instance, that combination of lopinavir and ritonavir, that ritonavir is not really being used to inhibit the virus so much. It's being used to boost levels of lopinavir in order to get that to suppress the virus more. Because ritonavir itself is not great, but you're able to use it to boost other drugs to make them work that much better. So if that makes sense. Next one is a group called the CCR5 Antagonist, and this is one drug called Maraviroc or Cellzentry. This one does work on both HIV-1 and 2, and this one's actually kind of interesting. So this one doesn't have any effect necessarily on the virus, but it's affecting the human receptor. So those cells that express CCR5, this will help to block that. However, though, this is only going to be useful for viruses that are looking for that co-receptor in order to gain entry into the cell. They can eventually develop mutations to where they're not even looking for that. They're just using that CD4 receptor to kind of grab onto the cell. And so this is why resistance testing is important for this one. Again, probably not going to be seen early on in treatment, probably more so for those resistant cases where you kind of know what the resistance pattern already kind of looks like. Again, pretty well tolerated, but rash, hepatotoxicity, you're definitely monitoring liver function for the majority of these patients at baseline and at follow-up anyway. So again, this would be another one you want to be kind of looking for. So this is another very important class, is the integrase inhibitors, sort of the newest out of the bunch. Here we have raltegravir, dolutegravir, elvitegravir, and then bictegravir. So if you see the gravir, then you can know it's an integrase inhibitor. And so basically this helps to prevent that viral DNA from being incorporated into our actual DNA. So that way we're not sitting there replicating the virus for it. These are very well tolerated. You can see here rash, nausea, some headache. Nothing like you're going to see with some of our, especially old school NRTIs and things like that. And so these are now what's often recommended as sort of like first-line treatment, or the part of the regimens for the first-line treatment for new HIV diagnoses. Here's some other examples where we can actually use co-formulations of using cobicistat as a 3A4 inhibitor to boost levels of the elvitegravir in order to make it more effective, basically, because the levels are going to be higher there. And again, we can see some combination products as well that really help out with the compliance. That way, maybe the patient's only taking one tablet a day, which is fantastic. So here's an example. We have bictegravir co-formulated with emtricitabine and then tenofovir. So 2 NRTIs plus the integrase inhibitor. I'll talk about the regimen specifically here in just a little bit. Someone said, so you'd give a protease inhibitor with another protease inhibitor in order to increase levels of one of them. Yeah, so ritonavir specifically, or that drug cobicistat, can be used in combo with another protease inhibitors to boost levels of that protease inhibitor. Okay, so the level's higher, it can in order to treat that virus there. So in some cases, you'll see it done sort of ad hoc, where you have 2 separate pills, like you'll take ritonavir plus a pill of something else, like nalfenavir or something like that. Or you could just use the combo. So if there's like, Kaletra as an example of the combo of the 2 put together already. You can keep asking the questions. I don't mind talking about this stuff. Even if you think you're like, man, I don't want to sound silly, that's okay. That's why they have the anonymous sharing. No problem. Anyway, so as I mentioned, drug interactions are numerous and quite common. I'll never forget one of my first rotations when I was in pharmacy school many years ago was at a family practice that actually had a family medicine practice that had, of course, in Palaca, Florida. And it had pharmacy built into it. But at that pharmacy, we actually had a Coumadin clinic that we ran. So we did a lot of warfarin dosing for things like that. And so that was like my main job. Was I would have patients come in on warfarin. I would help to check their INR. We had a little, finger stick pointy care INR test. And I'll never forget like one of my like biggest challenges. I was there for 6 weeks. I think I was there for 8 weeks actually. Was one of the biggest challenges there. I had a patient who had Hep C, which we're going to talk about later on, and they were HIV positive as well, and on Coumadin because they had a history of AFib, and we didn't have the newer NOACs available to us today, like Eliquis and stuff. So this person was really such a challenge because we'd find that as their HIV regimen might change, now all of a sudden they have fewer inhibitors on board. I mean, now they have some inducers on board. Some of the Hep C meds may have had some interactions. It just made it a really big challenge. So it took me like the entire 6 to 8 weeks in order just to get his INR therapeutic. And so it was really, really big challenge. So always double check the interactions report to see if there's something kind of goofy is going on. But anyway, so most of the interactions you're going to see here are going to be through 3A4. So as an example, efavirenz, etravirine, and nevirapine induce 3A4. That may cause some drugs levels to drop, like simvastatin or something like that. You'll see most of the protease inhibitors tend to inhibit CYP3A4, if anything. And then always keep in mind other drugs they might be on pretty commonly. So things like TB drugs, if they have a co-infection there, like rifampin is going to be a strong CYP3A4 inducer. Going to drop in levels of those protease inhibitors potentially, or other drugs. You'll find some of these drugs do require specifics in terms of like how you consume them. So like some of them require more of an acidic environment to be absorbed. So you may want to see some of these maybe an empty stomach, eat with food. Again, I'm not going to get super in the weeds on that. You can look up that kind of stuff. And again, if you're ever in doubt, make sure you're looking up to date recommendations. I mean, UpToDate's going to have up-to-date recommendations, but things like HIV info, all that's going to have really good information for you in your page. So the question is, so how do we actually treat this? I guess I should update this thing. I just look this up. Now it's HIV info. I wonder when they did that. It wasn't too long ago. Anyway, so you can look this up. Again, you can just Google HIV info to get the same thing. And so you'll always find new recommendations. Things will change. There's been a recent recommendation. There's some long-acting injectable forms, which are not recommended first line, but are out there. But what we do know for the most part is that initial treatment generally should be managed with a minimum of 3 antiretroviral drugs. There's a couple of options you could do with just 2 drugs, but most of the recommendations you'll see tend to be a 3-drug regimen, which is most often going to be an integrase inhibitor plus 2 NRTIs. Those are kind of the most frequently recommended ones out of the group here. So as an example, you could do raltegravir plus tenofovir plus emtricitabine as an example. Okay. Other options that you could potentially do, maybe they couldn't receive an integrase inhibitor for one reason or another. You could do a protease inhibitor plus 2 NRTIs. Here's an example. You'd see darunavir, which could be boosted by ritonavir. So that's now a 4-drug regimen plus tenofovir emtricitabine. Okay. Notice there's always that backbone of 2 NRTIs. That is the most common thing you're going to run into. Here's an example of an NNRTI. This is going to be less preferred, but you could do efavirenz plus tenofovir plus emtricitabine. Okay. I'll tell you right now, there's going to be a test question going to come up, and it's going to say which of these regimens looks like a legit recommendation for a first-line treatment for a new HIV patient. And I may have some options on there where I have like 3 protease inhibitors, and that's obviously going to be wrong. I may have one where I have 4 NRTIs. That's obviously going to be needs to be some kind of combination like the ones that are seen here. Your job is to be able to look and recognize the drug, say what class they go into, and realize whether or not that's going to be part of an acceptable regimen. Okay, so again, I don't mind telling you that ahead of time because you're going to be doing this anyway, trying to recognize these drugs and what classes they go into. But that could be it's going to be one of the things you're going to see. I guarantee that question will be on the exam, but I always change up the different drugs and the different combos every time. So I don't feel too bad about telling you that because I think it'll still provide plenty of challenge for you regardless, just because getting acclimated and getting used to seeing these drug names is a challenge for sure. So anyway, so adherence is can be quite variable, especially depending on the patient's situation. So you have to think about everything else going on with the patient's life. Do they have a stable home environment? Are they unhome perhaps? Do they have concomitant IV drug use? Do they have, concomitant psychiatric illness? There's all kinds of different things that could be leading to poor adherence. Also, the drugs can be kind of rough. So, if they feel worse taking the drugs than they did before, then they may not want to take them, right? Which is why it's always really important to educate, why they need to take this, to say, like, hey, if you want to live a long, full life, this is what you got to do, right? Or try to find regimens that help to mitigate some of those adverse effects if at all possible. In order to help out with the compliance, use combo formulations whenever possible, and it'll help to limit how many pills they need to take in a day. Because again, it's not only this they may be treating, but also maybe Hep C. They may also be treating diabetes and hypertension. So again, you want to keep things simple whenever possible. It also helps to limit some of their food restrictions too, if they can just get it done one time of the day. So as an example, here's some combos you can run into, like efavirenz and tricytidine tenofovir. Some that include integrase inhibitors that are probably going to be used a little bit more frequently. So again, there's lots of them that are out there, much more so than even when I was in school, which is great because it definitely helps out with the quality of life of these patients quite significantly there. So let's talk about resistance testing a little bit. There's two main types of resistance testing that you're going to run into. There's what we call phenotypic testing and genotypic testing. Okay. Phenotypic testing tends to be more of what you would typically think about, like a culture and sensitivity with like an antibiotic or like a bacteria that the patient was growing in their lungs or something, right? Where you can actually see, okay, you actually plate out the bacteria and you give it little discs of antibiotics to see which ones it's susceptible to, intermediate, resistant to. That's kind of what they do with phenotypic testing. They will go ahead and culture out the virus that the patient is growing, compare it to a wild type that should not have any mutations. And what that does is it allows to actually see in vitro, basically, all these complex interactions with the different mutations that it has and what that actually means for resistance to the various drugs. Now, this is much more involved, so it's higher costs, slower turnaround time. So frequently what you'll end up starting with is what we call genotypic testing, where they can sequence out the virus and see, okay, we'll see what mutations it has, compare that to a database that says, okay, well, this mutation generally confers resistance to efavirenz. So we don't use efavirenz in this patient here, right? But again, when you have something that has a lot of mutations to it, the interplay between those can be quite complicated, which is why the phenotypic testing, it does provide you more information, but the genotypic testing can be done much more easily, right? Because you're just looking at the sequence of it, comparing it to the database that you have, but again, doesn't give you the whole picture. So that's kind of the differences between the two testing types. Generally, people will start off, once they get the diagnosis, you'll start them off on one of the approved first-line regimens, usually including integrase inhibitor and 2 NNRTIs. You'll do the genotypic testing at the same time. That way you can kind of see if there's anything that may preclude them from getting one drug or another. And then if you need to, when things get more complicated, maybe if resistance is developed, the patient's on the regimen, but they come back and their CD4 counts, is not moving in the right direction, their viral load's still high, and you assess to make sure the patient's actually taking it, then you can start to consider things like phenotypic testing to see, okay, what should you do from here? So that's kind of the general process for managing those patients there. So let's look at some special situations you might run into. First off, being HIV and pregnancy. Generally speaking, you will find that these patients get treated just like as if they were not pregnant. The biggest thing you want to do is make sure to get maximal viral suppression, so that way the fetus has as little exposure as possible. This is the thing I was looking for earlier when I thought I was missing a slide, but you definitely want to avoid the drug efavirenz, which is an NNRTI, mainly because that can cause neural tube defects. So that one would be contraindicated, especially during the first trimester there. And then we will find that once that baby is born, we can actually use zidovudine, and that is used to help prevent transmission, especially if the baby's born vaginally. They could potentially pick up any viruses there in the birth canal, and typically we'll kind of continue that for 4 to 6 weeks or so after birth, and that should, for the most part, prevent any sort of infection from sort of taking hold in that case there. And again, avoiding breastfeeding is generally recommended as well. From a chemoprophylaxis standpoint, there's a couple of ways you can look at this, couple of situations. First off being for healthcare workers for post-exposure prophylaxis, or PEP. You ever see that? Most organizations will have some sort of protocol on what to do if you have an accidental needle stick exposure. I'm pretty sure they're mandated by a Joint Commission to have one, but and so if you have a high-risk exposure, like for instance, if you got stuck with a needle, but then for whatever reason you couldn't get a hold of the patient, so you don't know if they have HIV or any other transmissible diseases, then you can go along with sort of the most conservative sort of approach here. And this is normally done through like your employee health department that can help out with this. But preferably, you know, the HIV status of the patient. But if not, you go to the worst case scenario, because I'd rather go on this for a couple weeks and avoid HIV than accidentally getting it by saying, oh, well, they probably didn't have it. It's probably not a big deal. So typically you want to start as early as possible after the needle stick exposure or whatever, however you got stuck. So try to start that within a couple of hours. And typically we'll go with tenofovir, emtricitabine, and raltegravir. You kind of go the full court press of the full antiretroviral regimen for 4 weeks. That way, if any virus did happen to be transmitted to the healthcare worker, you suppress it as heavily as possible to make sure that no infection takes hold. And remember, a lot of these patients who do develop HIV outside of healthcare workers, you know, they have a long period of time where they have the disease before you really know it, because besides that acute retroviral syndrome, oftentimes you don't know that you have the infection. It's not until it becomes more apparent when, you know, the immune system has been more damaged as time goes on there. So again, if you can start early within a couple of hours, that's going to be able to provide pretty good prevention there, which is nice. Now, there is some pre-exposure prophylaxis that is done. This can be in cases where you have people who are engaging like in high-risk sexual activity. So, for instance, like receptive anal sex, I believe, is like one of the most transmissible types of encounters you can have for HIV. Or if you have patients who are like known IV drug abusers, or if you have serodiscordant couples, so one person has HIV, the other doesn't. That could be a case where using something like daily tenofovir and emtricitabine or Truvada can actually be used and help to prevent that. How long do patients on average not know they have HIV? That's a good question. I don't know if that data is available. I don't know it. But it's one of those things where, again, you can just think, okay, well, you had a random illness. It's not easily apparent that the patient, you know, that is due to HIV versus anything else. And so I think if you have patients who have, you know, high risk behaviors. So for instance, like you had a patient who was a known IV drug abuser who came into the ER, for instance, you might just check for HIV anyway, just to see if they have it, you know, just for your precautions, you know, in case they get stuck by a needle or something. And so you can kind of find it that way. Some people do routine testing to see if they have it, and so they may catch it that way. Otherwise, it could be, you know, months, maybe even more than a year before they would really know, because again, it takes time for the virus to really take hold and sort of cause enough depression of the immune system to cause a problem. Some of these patients you don't find out until they come in with TB, right? Or they have thrush. Like you don't normally see thrush in patients unless they're like, you know, they have some sort of immunocompromisation, and that could be your first clue to be like, hey, let me go ahead and check an HIV test just to see if you have it or not, right? So sometimes the opportunistic infection is the first time you actually know the patient has the disease or not, you know? So someone was saying here, do you know when neonatal transmission prophylaxis was created? No, I don't sure when it was first created. Sure, the recommendations have been around for a while. Probably not any earlier than the 80s, I would say. How about that? The best answer I have for that. Would PEP medications be covered by a patient's employer if exposure was at work? So generally speaking, my understanding is that and so for instance, like at the pharmacy where I work, you know, we would provide that medication to the employee health. And so we would be able to either, you know, we usually have like a physician who kind of signs off on that stuff. They're kind of like the physician of record for that department, and they would either be able to write for a script or they would be able to supply it themselves. It kind of just depends on the situation, on the organization. But generally speaking, even if you got like pushback from, and generally, if you're working at a hospital, presumably you have some form of healthcare. I mean, you don't have to, but you'd have healthcare. And if you had like some kind of some sort of like denial or something from that, you could easily get like an approval by going through and saying, okay, it's for this particular indication. This is why they need it. So generally speaking, insurances would prefer to cover this stuff, even if it's expensive, versus having to deal with the complications of treating, paying for treatment of complications of HIV and AIDS, generally speaking. But generally, we try to make sure it's like no cost to the patient there in that particular case. Kaylee had an accidental needle stick in blood banking. It was covered under the company. Yeah, so I think a lot of places tend to do that, but it may be specific depending on where you work. Because if it's like at a family medicine practice where it's like, one doc and one PA, like I don't know if they have anything necessarily set in stone with that, so it could be dependent. I think most big organizations will have something already figured out. And like you had a blood banking place, so like of course that's a huge risk. And so of course you have to be able to kind of cover for that sort of thing, that eventuality. But anyway, just one more thing here. If you're going to do pre-exposure prophylaxis, make sure to test the patient first to make sure that they are not going to already have HIV, because if they do, then they need the full treatment of that there. So that's be the one thing to note. Sorry, I forgot to go back to the slides. But yeah, so just that last point there, just make sure the patient actually does not have the disease in the first place. So as I mentioned, our evaluation of outcomes is basically looking at the CD4 count and the RNA load. Again, we generally will do that genotypic testing up front to see, did the patient get a strain of the virus that already had some mutations kind of built in. You don't want to delay treatment. You want to go ahead and start that initial recommended regimen, usually integrase inhibitor and 2 NNRTIs. And then once they're on that, you can monitor every 3 months until the HIV RNA is undetectable. The reasons why you might want to change the regimen is either one, they have an intolerable side effect. They have a treatment failure, and you've ensured that they're being compliant. So if the viral RNA is over 200 copies per ml, or they have documented resistance. So if you put them on something like, bictegravir, tenofovir, emtricitabine, and then they come back with resistance to tenofovir, then you need to switch them to something else, obviously. Anyway, so just to transition, let's talk about some of the complications of HIV and AIDS. And so you can kind of see here, looking at the kind of the time course of HIV infections in terms of the CD4 count, sort of what they become susceptible to as time goes on. So as I mentioned here, like oral candidiasis, thrush, that is not a normal thing to expect to see in a patient with a competent immune system. So that could be your first clue that, hey, something's going on here, right? So maybe we need to check for something like HIV, or maybe you ask them when they have cancer treatment. That would make sense, different things like that. But as the CD4 count goes lower and lower and lower, we know they're more at risk for having some of these diseases like cytomegalovirus, things like PJP pneumonia. So this is something we would like to prevent at all costs, because these can be pretty devastating to the patient. I mean, I've seen a few cases where it wasn't HIV specifically, but it was caught as a result of chemo treatment. But PJP pneumonia, I mean, those are some of the sickest pneumonia patients you're ever going to see, because they just don't have the immune system to fight back against it in a lot of cases. But yeah, so you want to try to prevent these as best you can. And I'm not going to cover every single one of these, but a few of the more high priority ones that we will see being managed fairly commonly, I'll kind of refer to. Someone said, is PEP the same as PrEP? Trying to think. You just want to make sure you're kind of keeping the post-exposure prophylaxis different than the pre-exposure prophylaxis. I'm assuming PrEP is more of a pre-exposure prophylaxis. I'm not seeing that term generally. Normally, like the way I interface with it is from like a hospital policy standpoint. So we always talk about post-exposure prophylaxis, because we don't really have people that we need to do pre-exposure prophylaxis for. But that would be my, and I'll make that distinction on the exam. If there's any questions, I'll say, hey, which one of these regimens would be good for pre-exposure prophylaxis in a serodiscordant couple? Patient has documented no HIV, right? Something like that, versus if it was post-exposure. So. And again, if you talk to someone who does this stuff every single day, they can definitely expand on a lot of things I'm saying. Again, I don't get to deal with this all that too frequently, We'll have the random patient who gets admitted who happens to be on some of these medications here. But beyond that, it's mostly just kind of looking at the regimen, making sure anything we need to prescribe for them is not going to interact, things like that. Isabel saying PrEP is for coming into contact with known HIV patients, like being in a relation. Yeah, so that's the pre-exposure prophylaxis there. So that's that P. That's I guess the R is there for the pre portion of it. So there you go. Anyway, so what we're going to see here is that two things can happen here. One is that as the patient's immune system sort of gets more and more compromised, you're going to see that just normal exposure to things we find in the environment all the time, they're more likely to get infected with. Or in some cases, it may have activation of latent infection. So it's not uncommon if someone had a latent TB infection for it to become activated as their immune system kind of gets more and more suppressed there. So our goal is to, one, try to keep the virus as suppressed as possible so that we can keep the CD4 count high. So the higher CD4 count is, the better it is for our patient, generally speaking. And then if we can prevent exposure to opportunistic pathogen, that would be great. And always be possible. So if we can try to maybe like vaccinate if it's feasible, we can do that. And then what we're going to see is we can actually do chemoprophylaxis at certain CD4 thresholds. So for instance, as you get below 200 CD4 cell count, we know that your risk for PJP goes up. So at that point there, we can initiate chemoprophylaxis. And I'll talk about what that is here in just a moment. If they do develop the infection, then we go ahead and treat that if we can, if we have whatever medication we're going to use there. And then once they have recovered from that, then we can put them on what we call secondary prophylaxis. And then generally speaking, once the CD4 count has recovered and say they go up above 200 again, then you don't have to really worry about the chemoprophylaxis. You could discontinue it at that point. Again, this is not an all-inclusive list. Stuff gets updated all the time, so you go and check it out on hivinfo.nih.gov. So someone says, well, I'm confused what the first line treatment is for HIV. So again, basically starting off with one of the regimens that I listed on there, most of the time nowadays they're recommending integrase inhibitor plus 2 NRTIs. That's going to be the most common sort of regimen you can see recommended first line. You can sometimes see protease inhibitors plus 2 NRTIs. Some rarely see an NNRTI plus 2 NRTIs. Those are generally the combinations you might see first line, but for the most part, integrase inhibitors seem to be predominating, mainly because they have a much better safety profile than you're going to see with things like protease inhibitors and NNRTIs, things like that. So hopefully that clarifies your confusion. If not, then let me know. But again, it could be different for every patient, because if you give, say you start them off on a regimen and they come back and they're resistant to one of those drugs, then you got to change it, right? That was the wrong first line treatment. You have to kind of adapt to that as things go on. So again, mix and match things as time goes on, or as the resistance patterns are being discovered through that. So just a couple of things here. So again, there are benefits to having the patient, and again, like I mentioned, sometimes the discovery of the OI is the first time you're going to realize that patient has HIV. So if someone comes in with pneumonia and then you test them and they have PJP, again, that's not normal for patients with a competent immune system. So again, that may be the first time you're discovering it. So obviously there's benefits to starting them up on antiretroviral therapy, because you're going to help their immune system to kind of reconstitute itself. However, it can be challenging, because if you're putting them on like treatment for TB at the same time you're doing antiretroviral therapy, that's a whole lot of drugs all at the same time. There could be a lot of interactions there. And there's actually something interesting that can occur called IRIS, which is the immune reconstitution syndrome, where basically the patient gets sicker, or seems like they're getting sicker. They just feel worse, because now that you're starting the antiretroviral therapy, their immune system is kind of coming back online and is starting to cause that inflammation and causing that infection that was kind of sitting there just kind of chilling out. Now it's becoming, now your immune system is actually fighting it, causing the patient to feel worse, even though they're getting better. So that can be a bit of a challenge there as well, and make patients maybe not want to stick with their regimens. So someone said, what does secondary prophylaxis mean? So like if I had a patient who, actually I'll show you just in a second here. Let me go to talk about PJP, and that'll demonstrate for you. So this used to be PCP pneumonia, but now it's PJP. They changed the drug name there. So sometimes you'll still see some older references talk about PCP, but nowadays I think PCP is mainly just referring to phencyclidine, or angel dust. But anyway, so this is the most common life-threatening opportunistic infection in these patients with HIV and AIDS. Basically, Pneumocystic jirovecii is a fungus that has kind of like protozoal sort of characteristics, which makes it kind of difficult to treat. And you're going to see that you've probably been exposed to it at some point in your life, but you have a good immune system, so you fight it off very easy. And you'll find it has this kind of insidious onset where they'll kind of develop this pneumonia over the course of weeks. Will happen here, and it can be quite difficult to manage. And oftentimes we'll actually start off with an IV Bactrim, and you'll realize that IV Bactrim is not something we ever use if at all possible. We always try to go oral if need be, but this is one cases there where we certainly will start off IV for sure. And they have to treat them for 21 days, right? So notice the treatment time is also a lot longer because we don't have a patient with a competent immune system to fight that off with the drugs. So the treatment is automatically 3 weeks. They're probably going to be in the ICU because they're going to be sick as snot, most likely. And so in order to prevent that, what we can do is to put them on prophylaxis beforehand. So we can go ahead and start them off on Bactrim. So sometimes if you see like thrice weekly Bactrim, or if you see like Bactrim twice daily for Saturday, Sunday, for instance, that is a pre-exposure prophylaxis, right? So what would normally happen is if you had someone who's on pre-exposure prophylaxis with Bactrim, right? So they've never had PJP before, but their CD4 count goes below 200. You start them up on Bactrim usually 3 times a week. If they develop the infection while they're on that, then you treat them for that 21 days. Let's say they recover, they're doing good. Then the secondary prophylaxis would be you'd put them back on that Bactrim thrice weekly in order to prevent another infection. Because again, they're not immune to this. They can get it again. It's just you're trying to prevent them from getting it a second time. So that's that secondary prophylaxis that we're talking about there. Someone said, so first line is integrase inhibitor plus 2 NRTIs, and if those don't work, you'll try a different regimen. So basically, so you could start that off first. That's what a lot of the recommendations are now is different combinations of integrase inhibitors plus 2 NRTIs. But let's say they couldn't receive that because of side effects or due to whatever reason they couldn't get a hold of the drug, then you could try something like a protease inhibitor plus 2 NRTIs, or rarely an NNRTI plus 2 NRTIs. But again, you mix and match depending on what the resistance comes back as. If it shows they're resistant to like emtricitabine, then they can't be on that. So you switch them over to something else within the NRTI sort of category there. But basically, for most patients, you start off with an integrase inhibitor plus 2 NRTIs, and then go on from there as resistance comes back. Basically, if you don't have to, don't change all 3 drugs, right? If you can't just change one of them and the virus is just susceptible to the other 2, just change the one, right? You may not be able to use a combo pill anymore if that was the case, but again, it is going to provide them a more sort of sufficient regimen. Hopefully that cleared that up about the secondary prophylaxis, if that makes a sense there. So with the secondary prophylaxis after having PCP, they would indefinitely be on Bactrim. No, not necessarily. So once their CD4 count recovers, if you can get it back above 200 for a period of time, then yeah, you could take them off of it at that point, right? So again, and that would be the case for primary prophylaxis as well. If I had someone who came in, say they were first diagnosed with HIV, CD4 counts 150, you're going to put them on Bactrim right away, thrice weekly. And then as maybe the ART started to kick in, the CD4 count elevates above 200, then you could stop the Bactrim at that point, right? So that's always the key point there, is that you only need the prophylaxis while their CD4 count is below that point, because that's when we've been able to show that risk goes up pretty significantly. And again, could they get it at 205? Maybe, but or could they not get it at 195? Probably, but again, we use those guidelines just for the general population. What could you use for someone with a sulfa allergy? There are other options that are out there. So, for example, we have some patients who cannot get, and again, I don't deal with a ton of HIV patients where I work, but I do see a lot of cancer patients who are in a similar boat of being neutropenic and being at risk for things like PJP. And so in those cases there, we use a different drug called pentamidine. Pentamidine, they can actually get that once every 28 days. And so frequently, as they're coming in for their chemotherapy, they'll give that pentamidine at the same time, either as an inhaled form, because again, it's going right to the lungs where that PJP likes to hang out, or we do it IV. So I didn't want to get too lost in the weeds here, but that would be what I do for those patients there. If a patient is resistant to an NRTI, would another NRTI work, or would you have to change a different drug class? No, so NRTIs are always going to be the backbone of these regimens here. So you can switch within the NRTI class there. It was only the NNRTIs where resistance to one conferred resistance to others. Now, again, you just have to go with the testing to see like, okay, well, which NRTIs do I have available to me? And then you could pick from that list basically to see, okay, which ones do I like to go with here? And again, hopefully they don't have a really resistant strain that they got, but again, we can't really guarantee that depending on where they got it from and whatnot. So once CD4 levels go above 200, you can stop giving secondary prophylaxis. Yeah, generally speaking, my understanding is that they can certainly come off of it if they have a good sufficient recovery of their CD4 count. Yep. Because again, the risk is really based on what their CD4 count's doing, because that's telling me how competent their immune system is, basically. Right. So as I mentioned, like candidiasis or thrush, you may see this in patients who have like inhaled corticosteroids, right? So like, fluticasone inhaler or something like that. You can certainly see cases of thrush. But otherwise, thrush is not a normal thing. You'd expect to see this in patients who have depressed immune systems. The problem with this is, and this is kind of similar to what we saw with patients being treated for cancer, is that we worry about these patients not necessarily the plaques in the back of the throat. That's not really that bothersome. It's more so if they get more invasive fungal infections. So if this becomes systemic, these can be extremely difficult to treat here. So in these cases, in order to, if we think it's just sort of a pharyngeal sort of candidiasis, then we can use something like nystatin oral liquid. This isn't going to be recommended if it gets more involved in esophageal. That kind of increases their risk for it going systemic. So in those cases there, if it's just oropharyngeal, yeah, nystatin oral liquid's fine. They can swish and spit, swish and swallow, and that's perfectly fine. I probably have them swallow it just in case there is anything down in the esophagus, to be fair. But yeah, they can do that, and that's good because really limited systemic exposure. But if they do have something like an esophageal infection, this is where I'd probably opt to go something like fluconazole. And again, long treatment durations here because they don't have an ability to mount a good immune response to it, in order to prevent any kind of systemic infection from happening there. And certainly there's been cases where they get really nasty, like fungal pneumonias. I mean, you have these big fungus balls that basically grow in their lungs and can sometimes be removed. It's pretty wild for some of these more severe cases. But for this one here, there's no specific recommendations for prophylaxis, so you really just kind of treat it as needed. So for some things, there'll be automatic cut points for prophylaxis. Other things will be sort of a treat if it sort of presents or if it comes up, basically. So other opportunistic infections on note can be things like cryptococcal meningitis, toxoplasmosis, Mycobacterium avium complex. All these things here. Again, I'm not going to get into every single one of these because we'd be here all the rest of the semester basically talking about all of these. But again, you will find that there's different regimens for prophylaxis for some of these. Again, if there's any vaccines they can get while they have a competent immune system, that's going to be recommended in order to try to prevent these from happening in the first place there. But so again, try not to get too lost in the weeds, just trying to get you at least some exposure to this stuff so you can at least be familiar if you see it out there on your rotations, for instance. So other complications here, as I mentioned, these patients are living for a whole lot longer. I mean, those diagnosed back in the 80s are few and far in between because we just didn't have good treatment for them, unfortunately. It took a while for all these nice new drugs to come about, like our integrase inhibitors. And so, we're seeing that they can be a risk for things like hypertension, cardiovascular disease, etc. Other things that can pop up that are particularly unique to patients with HIV include this nephropathy that can happen. You gotta look out for their renal function over time, and they do have risk for certain types of cancers, so things like Hodgkin's lymphoma, things like that. So again, as they're getting these new diseases, you have to look at the medications and make sure they're not going to really interfere with their HIV regimen. So for instance, if you see they have hyperlipidemia, make sure you avoid something that's going to go through CYP3A4 because that ritonavir is going to boost levels of that simvastatin, and now they're coming in for hepatotoxicity or rhabdo or something like that. So again, always be really, really cautious anytime you're adding on a new drug to one of these patients' regimens. Now let's talk about sexually transmitted infections or STIs. Again, I put this car here because it's an STI and this is what I drive. So I remember when I got my car that my wife said, "Great, now my fiance has an STI. I hope I don't catch it myself." And I said, I don't think you have to worry about catching this one. It's pretty fast. Also, it's kind of funny. There's a little knob in the car for the center differential, and it gets abbreviated as C diff. So she got in the car and she's like, "Great, now the car has C diff too. You got to do a whole clean out of this thing." But anyway, so yes, I love my little Subaru. It's fun. So let's go through a couple of these These, again, these will have new recommendations come up. There's actually one I'm going to give you a little bit of a controversy here, a little bit. Well, maybe maybe you already encountered this, maybe between a few of your other professors, but we'll talk about that as we get to it. Actually, kind of another funny aside, just real quick. I had one time when I was younger, I was going on a walk through my neighborhood. It was like a different neighborhood than I live in now. And I remember seeing I had music playing in my ears. I had like some, I don't know, death metal or something going. And I remember seeing a guy in his driveway, and I noticed that he had a WRX, which is like the little less sporty version than an STI. I don't want to get into semantics, but anyway, he had a WRX, and so I was like, "Hey, I like your car." And the guy, kind of waved back, and I not realizing how loud I was talking, I was like, "I have an STI," in the middle of this neighborhood, which is probably not something you want to announce to the world. But he kind of gave me a funny look, and then he walked back inside of his house. I don't blame him, Anyway, but regardless, it's just not things you want to be announcing to people in the world. Sometimes you got to keep your daily driver secret. Okay, so let's talk about some of the common STIs we're going to be running into. Gonorrhea is going to be the first one. It was a gram-negative Diplococcus. And so a lot of times you're going to see that these kind of conditions here, they tend to be asymptomatic in a lot of cases here. And this is what leads to a lot of spread of these disease, especially gonorrhea and chlamydia. There's a lot of asymptomatic cases why they keep kind of getting spread around. You'll also find that women tend to kind of get short shrift when it comes to these, because they tend to be more the ones that become symptomatic. They also tend to have more complications from these, and so this is why it's important to make sure that we treat these promptly and get it knocked out. With gonorrhea specifically, we can see things like infertility, pelvic inflammatory disease, systemic infections, and not only that, but it's interesting how these different disease states can sort of interact with one another, where HIV spread happens easier in patients who have gonorrhea, right? So transmission of these diseases can be changed based off of that, which is pretty interesting and not great. You're going to see here that the CDC still currently recommends a single dose of IM Rocephin for gonorrhea specifically. Now, the challenge here, and again, this is something where gonorrhea and chlamydia are typically pretty common bedfellows, so to speak, and so you're going to find that frequently you will end up treating for both at the same time, just because, again, that chlamydial co-infection can be sort of asymptomatic and silent at that point. And so the challenge, though, is the compliance with this stuff. And so if you can do something that's like recommended just as a one-time dose, that is very easy, because they can come into the urgent care, the ER, you diagnose them with gonorrhea, say, okay, let me go ahead and give you a one-time dose of Rocephin and azithromycin, and then you're done. Like, you don't have to do any further treatment. The patient's guaranteed to be compliant because you saw them take it, right? Or you gave it to them in the course of the IM shot. However, what we're starting to see nowadays is that, from the CDC at least, they are saying now that the resistance to azithromycin, so chlamydial resistance to azithromycin, is increasing. And so because of that, that 1 gram PO dose is sort of becoming less effective, right? So now they're recommending the doxycycline 100 milligrams twice a day for 7 days. So now they have to go get a script filled. Now they have to go and they have to start taking this. They have to remember to take it twice a day for 7 days. You can already see there's several barriers there, which makes them perhaps less likely to complete that full regimen. So you kind of have two things to kind of balance there. One, we know that azithromycin is becoming more resistant as time goes on, so that can lead to treatment failure, but also giving them the doxycycline script can make it more difficult for them to be compliant just from natural human nature. So I don't know what the perfect answer is for this one here. The CDC still recommends the doxycycline as first line now, even though that's certainly not ideal from the compliance standpoint. So I don't know. Some providers, I'm sure you'll still see, will do the 1 gram of azithromycin. Some people do the doxy. Again, I don't know if there's going to be a perfect answer that's out there that fits every single patient, but you can at least do your job and try to educate thoroughly and say why it is so important that they take this. Why did they complete this full 7 days? Why can they not just get a 1 gram of Rocephin or of azithromycin? Because again, the resistance patterns are there. So, but luckily, gonorrheal susceptibility to ceftriaxone has remained good, so that is still the recommended thing there. So at least a one-time shot for that, and they're done. If they have a cephalosporin allergy, try to investigate that to see, is that actually true? Could they possibly receive a cephalosporin? Maybe they say I was a penicillin allergic. Rocephin, if they had a really true penicillin allergy, they can still get Rocephin. Like, that cross-reactivity is so low that it's very unlikely for that to be a problem. But other options may be things like, fluoroquinolone, like gemifloxacin, gentamicin. Not really a ton of good options there. If you had a child or an infant that ended up developing gonorrheal infection in the eye due to, like, say, birth or during birth, we can do some things like topical erythromycin. Remember, topically applied drugs get very high concentrations, and so that usually has pretty good activity there. So, someone said, if you do Rocephin plus Azithro, could you still give Doxy RX, or would that just cause more resistance? I don't know that I would do both. I think that's probably kind of overkill at that point. I could see where you're coming from in terms of, like, trying to cover both your bases there. And I don't know there's any recommendations to say to do that. And, generally my mantra is if you can do fewer drugs, that's good. But I commend your efforts. I don't know if that would be something that many people would try to do. I don't know, from a resistance standpoint, I would not think that would really help a whole lot, mainly because if it was susceptible to the Azithro, the doxy's not really going to be doing anything at that point. But if it was still resistant to the Azithro, then the doxy's going to kind of kick in. So I don't know if there's a really good answer to that one. But again, I like fewer drugs if possible. All right. For chlamydia, we're going to see here, this is the second most frequently reported STD behind human papillomavirus. Again, a little bit outdated info, but you can still see here it's quite common. And it's probably a lot higher than that just due to underreporting, right? Because, again, there's a lot of asymptomatic cases, more so asymptomatic with this than you'd see with something like gonorrhea. So, again, tetracyclines, Doxy is going to be considered first line nowadays. Doxy specifically because it's, like, cheap. I mean, you can get it free from Walmart at the very least, or Publix. The fluoroquinolones may be used as, like, a secondary agent, but those you may want to avoid using in pregnancy. Again, so in that case, there Azithro would probably be a safer bet if you had a pregnant patient, but I'm not sure if the guidelines are that specific. I haven't read through them with a fine-tooth comb just yet. Let's see here. Someone said, would you want to retest someone that was treated with azithromycin? Again, the whole point of doing the Azithro is that you don't have to worry about seeing them again, because the idea is you have that insured compliance, and it was susceptible enough that you say, okay, I gave them the Azithro, I know they're treated, I know they're done. I don't know that you'd want them or be able to necessarily get them back in order to do that, right? So again, if you are giving someone a Azithro, it's probably someone you think might have less risk for being compliant, or has a greater risk for being non-compliant, and that type of patient may be less likely to come back to see you in the first place anyway. So maybe it could be one of those things where you kind of gauge it based off of how how you feel for the patient. Like, could you actually get that person to come back? In an ER setting, probably not, but how well do you think they're going to follow their PCP? Maybe they will, maybe they won't, right? So that's always a hazard, because once they leave you, it's impossible to say what they're going to do, unfortunately. Okay, if you had the patient come to the ER who got GC swabs and one came back positive, the other didn't, you could skip the other med, right? It's not gonorrhea, but not chlamydia. Would you only need to use a Rocephin? My understanding is yes. We don't do a ton of those, though. I don't really run into that a lot in the peds ER, fortunately. But I'm trying to think of any specific situations other than otherwise. Professor Lack might be a good person to ask about that if you're going to see her anytime soon. Yeah, I would say so. That I'm not 100%. I would imagine you could skip it, but I don't want to speak definitively on that just yet. I think one of our lecturers said we're supposed to retest patients who are positive GC in 3 to 6 months anyway. Yeah, so if you're going to see them, if they're going to come back to you. But again, the question is, are you going to be that provider that sees them again? If it's an ER setting, probably not. You're not going to come back to the ER just for that. But again, if you're more on the family care, family practice side or internal med, maybe you do see them, right? So that could be something to consider there. So follow-up is always going to be a challenge with these patients for sure. Question, I'm like, I love how engaged you guys are. This is like, makes it much more tolerable for me. It makes it much more interesting than me just screaming into the void for 2 hours or so. This is another case. If you had a infant chlamydial infection, topical erythromycin is going to be totally fine for that as well. Next, we have syphilis, which is Treponema pallidum. It's a spirochete. So again, kind of oddball sort of organisms here we're seeing. This is very highly contagious. You see this a lot reported, especially in like the men have sex with men population. This tends to spread fairly easily there. And again, we like to treat this mainly because of the fact that if the disease becomes more systemic, you can run into a lot of issues. Oh, sorry. I knew I was going to do that at least once today. My goodness. I was so good before, but then I get towards the tail end and I get sloppy and I forget. Jeez. Yes, I'm sorry. I switched to the slides already. You can put that on my reviews. Unable to switch slides consistently. Worst professor ever. Anyway, so what you can see here is again, we want to avoid things like developing like neurosyphilis or other systemic problems there. So here, luckily though, we've seen syphilis has still remained pretty susceptible to penicillin G. So this is really still the go-to drug here. Unfortunately, you're going to find that because of this slow growth of the Treponema pallidum, it does not really respond well to single-dose medications. They generally don't stick around long enough. The exception to that being is that benzathine penicillin G. Let's see here. I think I misspoke there. It should be topical. Apologize. Thank you for catching that mistake. That should be topical erythromycin. So since it's ophthalmic infection there. Thank you. Anyway, so here we're going to see the benzathine penicillin or bicillin is going to be good for a single dose. That's that long-acting intramuscular form that you can give. Kind of looks like it's in a milk sort of base or a lipid base. So that one can be used. That would be just a single dose therapy for that. If they could not get the penicillin G, then you could do something like doxycycline or tetracycline. However, treatment time's pretty prolonged. It's like 2 to 4 weeks because it is fairly slow growing. So that's why we like to use penicillin if at all possible. Again, if they say they have a true allergy, try to investigate that a little bit further. You know, if they say they had diarrhea or they vomited, obviously not really an allergy there. So in some cases where we have like more advanced like systemic disease or if we develop neurosyphilis, those are some cases where you'll occasionally see actually continuous penicillin G. So it's like a continuous infusion of that given 24/7. And so those are typically pretty sick patients up in the ICU. You may see that it's probably related to syphilis, or maybe could possibly be like a case of endocarditis. But those are two of the big things I think about there. So up next is going to be genital herpes. Again, this is another kind of disease state where patients can be very asymptomatic and still spread it to others. Sometimes doesn't become symptomatic for a really long time in cases there. Someone said, you said there's a little cross-reactivity with Rocephin and PCN. Does this hold true with all cephalosporin classes? So if you look at the data, and again, it's hard to do like randomized controlled data to say what the actual true rate is, but if you actually look at the data that's been kind of collated and put together, the highest risk tended to be with the first generation cephalosporin. In that case there, it was still less than 1%. But it tended to be a little bit higher with the first gen cephalosporins like, you know, cefazolin, cephalexin. Those tend to be more so. The higher generation ones tend to have even less risk. So again, if I have someone who says they have a true blue anaphylactic allergy to penicillin, I feel very comfortable giving them Rocephin, right? And I've had several cases like that in the ER where I have, especially like a little older school providers who didn't get, you know, up to date info like this, and so they said, well, I don't want to, you know, try to, you know, push the envelope here. Let's just give them like a fluoroquinolone or something. I was like, we don't really need to. Let's just give them a test dose here in the ER, see how they respond, and go from there, right? So, you know, if they can get a dose of a ceftonir or something, a third gen in the ER, watch them for 30 minutes, no problems, okay, then send them home. I've never had an issue where I've actually seen someone have a cross-reactivity. Doesn't mean that it can happen, just means it's very low risk, and it's generally, because again, if you can avoid having to shut out an entire class of antibiotics for a patient for the rest of their life, that's a good thing, right? So that way they can get it in the future too if they need to. So anyway, looking at genital herpes, and again, I go back to the slides. Here you're going to see that, again, pretty common infection you're going to have here, HSV 1 and 2. Again, they're not just totally relegated to upper and lower. Here you can see HSV 1 causing genital disease and vice versa. But again, a lot of asymptomatic infections here. And even if the patient doesn't have active lesions, you can still see, you know, viral shedding. And so really it's important to try to identify those patients that do have the disease that we can intervene and try to prevent future spread. So our goals here, so when the patient's having an acute acute episode. We want to be able to relieve symptoms because it is pretty painful and irritating, and try to shorten their clinical course if at all possible, and hopefully prevent complications and recurrence there, and hopefully decrease transmission to other people if at all possible, right? In terms of like the pain and discomfort, we can use things like antipyretics. You can use things like, antihistamines. You can use analgesics, NSAIDs, Tylenol, that sort of thing there. Just make sure that they have good hygiene because, especially if it's itching a lot and they're scratching a ton, you can see secondary bacterial infections. So obviously that you don't want to complicate pictures any further. But here I want to focus more so on the treatment side for the actual virus. So here, the three main ones you're going to run into, especially for the first episode, is going to be acyclovir, valacyclovir, and then famciclovir. If you recall, valacyclovir is just a prodrug that gets converted in the liver to acyclovir to boost its bioavailability. Okay, so I see a lot of valacyclovir used orally, but then if they have like an IV need for acyclovir, they'll just get regular acyclovir. Basically, we'll do this for 7 to 10 days, and this helps to reduce viral shedding, duration of symptoms, and that time to healing, which is good. Big thing here is that the time frame is very important. So the earlier they get treatment started, the better it's going to work, basically. And so you're going to see here, topical treatment's not really going to be that effective, so they need to go ahead and get oral therapy for most patients there. Those that are immunocompromised, or if they have really severe disease, in those cases there, we may need to do things like IV acyclovir. However, that you're going to see a lot more side effects associated with that, like renal toxicity, you see bone marrow suppression, CNS toxicity. I remember we had one young girl who was a cancer patient, had bone marrow transplant. Immune system was like completely wiped out. Ended up getting an HSV encephalitis, and I mean, like, it was wild to see the CT scan on that patient. It almost looked like the brain tissue was like kind of moth-eaten. It was just kind of being pecked apart by this virus, and it was very, very sad to see. She unfortunately ended up dying, but so again, if you can prevent it from getting to this case here, that is always good. So for recurrent infections, this is where the time frame is really important, especially if patients can start therapy within no more than 24 hours after the lesion appears. This is when they're going to get the most benefit, right? Again, if you're going to have patients that have more like severe disease or they have really prolonged recurrences, they may have better use for episodic therapy. On the other hand, though, if they have like really frequent recurrences, and you want to try to suppress more asymptomatic viral shedding, then in this case here, you may want to go with more chronic suppressive therapy. They're taking every single day. This would be better for patients, especially if they're like partners who you don't know what their status is, and again, a lot of times testing is not super. There's a lot of false negative HSV tests that happen there, so that can be a bit of a challenge as well. So again, the question of whether you want to do episodic or chronic, I think a lot of people I've seen recently have been recommending more chronic just in order to prevent spread to other individuals, if at all possible. Next, we have trichomoniasis. So this is a protozoa we can treat here. You're going to see this oftentimes reported in women. For male patients, they tend to have a higher spontaneous cure rate. And you also see easier transmission from male to female, which again, just short shrift for the ladies here, unfortunately. Treatment for this one is pretty straightforward. It's going to generally be either a single 2-gram dose of metronidazole or tinidazole. And then again, these are actually within the same category in terms of how they're working. So these are sort of interchangeable depending on what's available to you. This is another one of those cases where you want to make sure that you're also treating the partner, because that does lead to better cure rate. You kind of prevent it from being spread back and forth amongst partners. And it's one of those cases where in Florida, like, we have a law available to where you can write a script for that patient's partner that you've never laid eyes on, in order to help prevent that kind of spread back and forth and into other people potentially. So, that is perfectly legal for you to do that, to write that script for that person, and then for it to be filled by a pharmacy and whatnot, and then given to the patient. Okay, so hepatitis is kind of the last big section here, and I don't want to necessarily break this up too much. So I think I'm going to go ahead and call it a day here, if that's okay with you all. Hopefully don't mind too much. But do you have any questions I can answer before I let you all go? Working on getting the rest of the slides posted up. I think your prescription assignment's already posted there. It's going over some ER meds. But let me, if you have any questions for that, I'm going to work on getting your assignment graded in a timely manner here. think it's due on the 23rd, maybe. So you got some time. But yeah. Anyway, thank you for joining me today. Hopefully you enjoyed it at least somewhat, and I will see you all next time. Have a good one. You guys are really nice. Thank you so much.